Comenzamos ahora una interesantísima sesión, la sexta de Área 2021, sobre innovaciones en cirugía del segmento anterior. También dirigida por José Luis Güell, mi compañero en Miranza, y por yo mismo. Tenemos un panel de debate de expertos cirujanos que van a dar su opinión sobre estas innovaciones, sobre su significado, su posible proyección y su realidad actual. Damos las gracias a Juan, Álvarez de Toledo, a Daniel Elíes, a Blanca, Poyales y a Karim Tourkmani, que van a estar con nosotros durante esta sesión, durante la cual vamos a tener importantes ponentes, empezando por Burkhard Dick, seguido por Vladimir Pfeiffer de Eslovenia, de Elena Arrondo y finalmente de Antonio Zavala. Vamos, antes de comenzar, a dar un mensaje de Johnson & Johnson y cedo la palabra a mi compañero Jesús Güell, que va a liderar la sesión.
Bueno, de nuevo, bienvenidos a la sesión 6, interesante sesión de innovaciones en cirugía del segmento anterior. En primer lugar, vamos a invitar al doctor Burkhard Dick, buen amigo. Welcome, Burkhard, and thanks for being here. I think that you're going to be live because I can see your face. So, without not more delay, just go in.
Thank you for the kind invitation. My name is Burkhard Dick, and I'm going to talk about recent innovations in cataract surgery and give you an update. My financial disclosure. I'm going to talk about capsulotomy techniques, laser cataract surgery, and pediatric cataract IOL technology, specifically addressing light adjustable lens and small aperture technology. But let's start with the capsular axis. Is this the evolutionary endpoint in capsular opening techniques? It has advantages, of course, as you all know, but it's also a manual step where you have centration issues, circularity, diameter must be perfect. So there is a desire to optimize this technology. And we are going to talk about precision capsule CT, the Zepto, the capsule laser, and femto capsulotomy technique. Let's start with the Zepto. It's a precision pulse capsulotomy, which uses an electric pulse nitinol ring for the cutting. It has a flexible handpiece, and the pulse is given an electric nanopulse. The diameter of the capsulotomy is 5.2 and needs an incision size of about 2.75. And then the device is inserted into the anterior chamber and really aspirates the lens with inducing a vacuum and then the suction. So here's the regular surgery. As you can see, it's a separate device. That means you need another assistant. It's then inserted into the eye, and then vacuum is then performed after centering the device on the visual axis, ideally. Then the electric pulse is given, and then you need to take care that you release the vacuum for the perfect anterior chamber maintenance capabilities. So initially we were very optimistic, and we were able to stretch also the the capsule excessively, as you can see here, but without any damage or something like that. But also when we more and more did this kind of technology, we saw that there were irregularities, cutting irregularities, which you can see here as a histological specimen. And in a trial, there were, of our 100 eyes, there were 27 attachments, which contributes to 28%, and 3 device errors. And the company then recognized they had an nitinol purity issue, which they solved and restarted with new handpieces. And then Abel and Vogt and others saw still with 50 eyes 2 capsular tears, which was, from my point of view, too high and unacceptable. So in summary, it's an automated capsulotomy, which offers a potentially good centration, but there are daily challenges, and you need an assistant trained in using the device. Also, there are some daily challenges and open questions, that is especially for the cut quality, the shape of the capsulotomy, and what about complex cases where it's advertised. If the lens is under pressure, for example, there's only little experience so far. Then another one technology is the capsule laser. This is a solid state laser that comes with a 590 nanometers. It can be attached to the microscope. It's easy to maintain, and the diameter can be selected from 4.5 to 5.5 and 0.1 millimeter steps. But the focusing is important and not so easy. Usually you use a contact lens, and here you see the technology. It's definitely you need to dye the capsule. And after the dyeing, then you need to center the ring and to also apply OVD on top of it, and then exert the lasing, which then is very fast and is then conducted, as you can see here. Using a scanning electron microscopy, Sharas Daya showed an outward wrapping of amorphous collagen, and a recent clinical trial from Pavel Stodulka had no complications. All capsulotomies were free-floating. From my personal use over years, I can say that it's an easy installation, it's user-friendly, and you can choose different diameters. Open questions remains. The implementation needs 5 minutes. And also, of course, there is a learning curve. And what about special conditions? What we hardly learned is that the posterior laser capsulotomy with this device is not possible. The femtosecond laser, in terms of vitreous loss, is now comparable with LCS of 0.65% and a manual 1.1%. It can be centered on different landmarks, so to say, pupil, limbus, as well as scan capsule, which we prefer, and especially the mini capsulotomy technique in the lenses that are under high pressure is extremely valuable. That means that you do a very small capsulotomy of maximum 2 millimeters, release the pressure, and then do another capsulotomy after irrigating the liquid fluid. Also have in mind that it's always great to have an anterior capsulotomy that's perfectly centered and in size. If there is something with the posterior capsule, you can then implant the lens into the sulcus and fixate it on the capsulotomy. Especially impressive are the results in pediatric laser cataract surgery. We've conducted more than 250 eyes now with excellent results. You can keep the anterior hilate membrane intact. You don't need an anterior vitrectomy if you use, for example, the back in the lens technology, and the cut quality is extremely good, but you have to adjust the capsulotomy size according to the age of the patient using the Bochum formula. And also, of course, there are different femto-IOLs that can be fixated into the capsulotomy, which is great, and more the lens designs are coming. Another interesting thing is in a biomorphometric detection of the iris, limbus vessel structures, and then the target axis is, so to say, positioned into the capsulotomy using these marks, where you then can align the toric lens accordingly. And of course, the primary posterior laser-assisted capsulotomy is also safe. That means that you don't have PCO over the years. It's easy to include at the end of the procedure. You don't need any manual capabilities. The only capability is to press the button. And you definitely can keep the anterior hyalid membrane intact in all cases. But so far, because the companies are not adjusting this, there is an additional click fee, which makes it uneconomically, and there's no specific program so far. But it is a very promising technology. Here you see the view through the microscope, and here 3 hours later at the slit lamp, where you see the anterior as well as the posterior capsulotomy, the disc disappears, not in the vitreous, in the space in between, and will not show up again. So in summary, the femtosecond laser capsulotomy is fully automized, is safe, allows you a 360-degree overlap of the capsule. In all cases, it's extremely facilitating pediatric and intumescent white cataracts, offers femto-IOL technology. It's a guidance for toric IOLs, and the PPLC is a new option, but the high costs, of course, is definitely a burden in this technology. Then let me talk about adjustable IOL pad technologies, and I'm going to talk about the light adjustable lens, which is now in a new lens design that has more UV protection and a proprietary injector that allows implantation through a 2.75 millimeter maximum incision. It has a new lightning delivery device with an LED lamp with less UV irradiance and new optical patterns, and it allows earlier adjustments, has a broader range in terms of correction, offers also an EDOF design, and also now comes with less lock-ins, and most importantly, most recently, offers the active shield, which protects the lens. That means that patients do not have to wear sunglasses, and during the lightning procedures, this active shield that prevents the UV coming into opens like a window and can be closed again so that adjustments can be performed anytime. There are presbyopia solutions. You can definitely offer an individually adjustable mini monovision and also induce negative asphericity. In trials that we conducted, we can really show that post implantation, but prior to the adjustments, the results were good, but after adjustments, they were tremendously better and improved by this technology. And 86% of the eyes in 100 eyes were within 0.5 diopters of MRSE and cylinder. And we just outformed with the new light adjustable lens the old results. So in conclusion, the light adjustable lens is safe and efficient, comes with minimal photic phenomena, and had a restart in Germany commercially. And we celebrated our 13th anniversary already with a happy patient, uncorrected distance visual acuity of 1.0p. And so in summarize, it's a great option to improve refractive outcomes, especially in post-keratory refractive eyes for advanced patient care. Last not least, the small aperture. Well, you all know that small apertures increase the depth of focus. This can be used, as from Agarwal here, with a small pupil or with the mask in the IOL. Prospective results were outstanding with this technology. Also, the mesopic vision was with and without glare normal. Binocularly, it compares well to the Symphony IOL in performance, and it can also be used binocularly, which we showed most recently, that enlarges the depth of focus, as you can see in here, in the defocus curve, and is very robust, up to 1.5 diopter in terms of corneal astigmatism compensation, and also interesting for odd eyes. So to say, extra focus then is the more aggressive way, so to say. And you can also laser this mask now into the lens, which is absolutely new. So in conclusion, this small mask technology comes with few symptoms, but that very high satisfaction is implanted into the non-dominant eye. So in summary, recent innovations need definitely controlled prospective clinical trials, verify their value clinically, and is very promising for better patient care. Thank you for your attention.
Thanks very much, Burkhard. Now we move to another good friend, Vladimir Pfeiffer, colleagues at the ESCRS for a long time, an excellent surgeon. He will focus on artificial iris implantation.
Dear colleagues, ladies and gentlemen, thank you for the invitation. The aniridia can be congenital or acquired, and it was introduced by Hans Reinhard Koch in 2000. My first patient developed cystic macular edema 2 years after implantation. Her visual acuity was 1-0, and I couldn't get rid of this cystic macular edema, and the artificial iris had to be explanted. Then this patient came to me. He was injured in 2011 and presented to me in this condition in 2013. I decided to do a surgery, as you can see it here, using a 9-0 Prolin suture and a lasso to fixate the artificial iris on 4 float sutures, and then secure the sutures with zigzag Zurmann's technique. This is the surgery. We did the penetrating keratoplasty. We did the trim the artificial iris to 10.5 millimeters, and then sutured the haptics of the IOL to the artificial iris using 9-0 Prolin suture and a lasso. Then this was implanted into the eye, and the suture was brought out of the eye 2 millimeters behind the limbus, and then it was centered, and the penetrating keratoplasty was finished using 10-0 nylon. This was done in 2013. Pictures postoperatively. There was no inflammation and no contact of these implant to the intraocular structures. Visual acuity 1-0 with contact lens, 06 with spectacles. Very nice situation. No edema, no inflammation, and good appearance, cosmetic appearance of the patient. This is another case. The best way to implant the artificial iris, I think, is into the capsular bag. And this was done here. This was a traumatic injury of the eye. The artificial iris was cut to 9 millimeters. Then it was put into the cartridge, 1.8 millimeter cartridge for the IOL, and implanted through 2.2 millimeter incision into the eye. The catheter was operated, capsular retention ring was implanted, and the 3-piece IOL was implanted into the capsular bag. And then this iris is glided using the Ogawa hook into the capsular bag too. It's done bimanually. With one hand, the capsular bag is elevated, and with the other hand, the artificial iris is pushed into the capsular bag. It's we are opening it and then implanting into the bag. And this is the appearance at the end of the surgery with nicely centered iris complex. This is the picture 4 days after the surgery, and this is 2 years after the surgery. Another case preoperatively. Here, the retina was detached, so silicone oil was used, and this is after the removal of the silicone oil. So in that way, patient presented to me, and this is how he went away. Another case, preoperative appearance, postoperative, and how patient looked like at the end. And he's now 7 years out of the surgery. Pre and after surgery, 17 years old boy. And here we were using the Brava technique. So we were using 30 gauge needle, 6-0 Prolin suture, artificial iris, and the IOL. And all this was implanted into the eye using Brava technique. As I said already, the flanges are done on 4 points. Then the sutures are brought through the incision out of the eye using 30 gauge needle. They are docked in 30 gauge needle and brought out of the eye. So this is watertight. Then they are cut away and flanges are done outside, and they are then pushed under the conjunctiva, a little bit into the sclera and under the conjunctiva. And at the end, the conjunctiva is being glued, appearance preoperatively and postoperatively. This is how the patient looks like today. Another case, traumatic injury before the surgery. Here the Yamane technique was used. So 3-piece IOL was pulled. We're using the Yamane technique, tucked into the needle and brought through the artificial iris, and then this was implanted in the eye, and the Yamane technique was performed, tucking the needle one side on the other side, and then both needles are pulled simultaneously out, or haptics are pulled out, and by doing this you can see how nicely the artificial iris and the IOL are centered. And then normally flanges are done on both sides. The incision was sutured and the conjunctiva was glued, because we want to have everything closed, watertight. The flanges are pushed back into the sclera. This is the appearance of the patient at the end of the surgery. Pictures post-surgery, appearance of the patient. And pictures again, how it looks like, and his appearance. And this is the last case, subluxated artificial iris. Patient came to me like this, and here I've decided to reposition it using a 90 Prolin suture and the lasso technique. So the first suture goes behind the artificial iris, out of the eye, 2 millimeters behind the limbus, and another suture is pulled, another part of the suture is pulled over the iris out of the wound, and this is a suture where we can make a lasso, and this is now tied around the artificial iris, and then zigzag suturing is done, and the gluing of the conjunctiva. This is his appearance at the end of the surgery. In conclusion, this is safe technique, results are great. Long-term monitoring is mandatory, and timely interventions also. I'm using a fiber-free artificial iris, and again, there should be no contact between the intraocular structures and the implant. Thank you for your patience.
Thanks very much, Vladimir, for these very nice surgical videos. Y ahora le toca a Elena Arrondo, excelente cirujana y gran compañera, que va a enfocar su charla sobre cirugía combinada de catarata y glaucoma con el excimer laser trabeculostomy. Elena.
Good afternoon. Thank you very much, Professor Alio, for the invitation to participate in this meeting. Excimer laser trabeculostomy is a microinvasive glaucoma surgery that creates multiple laser channels through the trabecular meshwork using a cold laser system. This system uses a 308 nanometer xenon chloride excimer laser, which creates 200 microns trabeculostomy openings through trabecular meshwork and Schlemm's canal, with a depth of 20 microns and a duration of 80 nanoseconds per spot. It causes cold photoablation of the tissue, therefore obviating thermal damage. The laser system received the CE mark in 2014. ELT was the first mixed procedure, as the first surgeries were performed in the late 80s. The procedure can be done standalone or combined with cataract surgery following cataract extraction. After placing the IOL in the bag, we will tilt the microscope 35 to 45 degrees away from the surgeon. Then we will rotate patient's head towards the opposite eye to improve angle visualization. The phytoprobe is then inserted through the main phaco incision or through a 1 millimeter paracentesis in the superior temporal quadrant to reach the inferior nasal area where we will perform the laser. We will perform a standard phaco procedure through a 2.4 main incision that we will use for the laser afterwards. Capsulorhexis, hydrodissection, phacoemulsification, and irrigation aspiration are performed, and we will remove all viscoelastic after the IOL is placed in the bag. Acetylcholine is injected to close the pupil for the laser after all viscoelastic is removed. We will inject the laser probe through the cornea, first looking through the microscope, but then under direct gonioscopic visualization, the probe is advanced bevel up through the anterior chamber filled with viscoelastic until we place it in direct contact with the trabecular meshwork. Usually 10 microchannels are created over 90 degrees, 500 microns apart. Blood and microbubbles are often seen after the laser is applied as a result of blood reflux from Schlemm's canal. After finishing the treatment, we remove all viscoelastic from the anterior chamber with irrigation aspiration to avoid IOP spikes in the early post-op period. We then pressurize the anterior chamber with hydrate the incisions to avoid hypotony. Sometimes, like in this video, Schlemm's canal is perfectly seen if it is filled with blood. This helps us locating the treatment area. It usually happens if the eye is not correctly pressurized with viscoelastic after the phaco is finished. This may cause some extra bleeding when performing the laser, but is easily removed with the irrigation aspiration system, and no bleeding is usually seen in the first day post-op. Bleeding is the only perioperative complication we have seen. And in case of a significant bleeding, this may require aspiration and a second injection of viscoelastic for better visualization and to be able to complete the procedure if all the 10 spots have not been applied. Again, it is usually easily removed with irrigation aspiration, but it is really important to pressurize the eye at the end of the surgery and after viscoelastic has been removed, as hypotony may cause increased bleeding in the early post-op period. A small bleeding might remain in anterior chamber, but it is usually gone in the first hours after the surgery is finished. The last review of the procedure, published in 2020, showed a mean IOP reduction between 20 and 40% from baseline, without medication washout and mostly a decrease in glaucoma medication. Few complications, mainly due to limited hyphema and IOP spikes, were reported. The higher the preoperative IOP, the better the response to the ELT. In our experience that is currently being analyzed, we have followed 62 patients that had undergone ELT combined with phaco from 2017 until July 2021. We have studied the efficacy and safety of the procedure. Mean preoperative IOP was 17.76, and the patients were on 2.02 medications pre-op. The mean follow-up time was 1.4 years, and our main target was to reduce the number of medications that the patients were taking after the surgery. Most of our patients had early-stage glaucoma and mainly primary open-angle glaucoma. Visual acuity improved from 0.59 pre-op to 0.88 after 3 years of follow-up due to the cataract surgery. IOP was significantly reduced after 1 year of follow-up, and the decrease that was observed was around 2 millimeters of mercury. We also recorded a significant reduction in the number of drops that the patients were taking after 1 year. But we have to see what happens after that time, as we have seen a few patients that have completed the 3-year follow-up with an increase in the number of drops. According to our experience and the published studies, we would recommend this treatment in patients with mild glaucoma, controlled with 1 to 2 drops, and with cataract as well. Thank you very much.
Thank you very much, doctora Arrondo. Muchas gracias, Elena. Y la última charla la llevará a cabo el doctor Zavala, Tony Zavala, otro excelente cirujano corneólogo y buen amigo, que se centrará en cirugía de la distonia de Fuchs.
This video shows a DMEX surgery. We use tissue that has been prepared at the eye bank, and it has already been dissected and scored the decimat. What we try is with trypan blue, we mark the edges and we flush the edge that has, as I mentioned, has been already detached. Sometimes only by fluid you can detach it completely, or you also can use a non-tooth forceps, as I'm doing here, to finally detach the whole tissue. This is usually of around 11 or 12 millimeter dissection. and we fold the Decimet in half as a taco, and we dry the surface and the stroma, the bare stroma that we gonna punch with a 3mm dermatological punch. That's what we do to make a little trephination to be able to mark our tissue. I find it crucial to mark the tissue because then I'm quite happy with the orientation, which as you know is very important on this type of surgery. Particularly if you're in your theater, you are not provided with an OCT. So then on the bare stroma we do this small 3mm trephination, and then we unfold the Decimet back with some fluid, as I'm doing here, and then we dry properly so that the Decimet attaches again somehow to the stroma. It's important to dry properly the edges so that you have a more or less firm attachment, and then you grasp the tissue and then just put it on the table, on the surgical table. To open the little graft is good to use a needle or just a sclerotom, and then you lift it up and you dry the surface. So here you have bare Decimet from the stromal side. You dry it properly before you mark it. You can use some already commercialized markers. We use this from Dartmouth and Kent, which is an S. This time it wasn't properly marked with the ink, so I had to finish myself with a marker just to make sure that the S mark was properly done. You have to dry properly because, as you know, the ink has alcohol and is toxic to the endothelium, and also if it's wet the ink will expand, and so your mark won't be as clear as it should be. So then we finish the mark and we dry properly, and we put the little trephine of the stroma, we put it back so that when we do the punching, it won't affect our mark. So once this is done, this is a very simple procedure which I copied from some other surgeon, and then we turn and we put it on the punching block. We choose here a 8mm punch. We adjust the graft so that we center the graft with the edges of the already prepared tissue, and then we press the punch slightly so we have a small it cuts properly. It's important that some of the punches do not cut so much. I find this classical Katina Hetzum Barrett very, very nice. Then you have to remove the ring of the tissue that it's being cut from the trephination. So in the center you have the 8mm already detached Decimet and marked. Then we lift it from the block and we put trypan blue and we submerge. We leave the graft here for about 2 minutes so that it dries properly with the trypan blue. 2 minutes after, we submerge this onto saline on a block, on a saline block. As you can see, you cannot see it properly because it's a blue one, but this is just the tape. On the microscope you can see it very well. And then we fish. I use this Gelder pipette, which I find very easy to just fish it from one side, and then on the other side we just put a 3mm syringe with some saline. It's also nice to have not to have any bubbles on the tip of your inserter on the cannula, and then we push slowly through your incision. This is a 2.2 incision, and we can rotate. As you can see here, we had a nice double roll tissue. That's the perfect configuration, and you can rotate it so that when you inject it, you still have this double roll configuration, which is ideal. Here you have to make sure that the eye is soft, so I usually, before I remove my injector, I make sure that the eye is soft, and I also make sure that the incision, I have a second instrument to make sure I can close the incision with it or push it so that the tissue doesn't come out. And then we put a suture, secure suture. And this is an uncut video. I already done decimatorexis under viscoelastic, which is not shown because it's quite an easy procedure. And this is an interesting case, but because as you would imagine with this double roll configuration, the unfolding could be very easily, but it wasn't because the AC was really deep and it was difficult to make it shallow. So I had to press with my fingers sometimes at the side of the sclera to make sure that I had a shallow AC. So it's always this equilibrium, this either you want a shallow AC so that it doesn't fold again, and then some AC so that you can unfold properly. So you're always playing with this tapping on the graft to unfold it and center it before you unfold it completely. And then, as you can see here, I like the two cannulas. Usually I use 30 gauge, but you can also use 27 gauge. And then from the paracentesis or the main incision, you try to flatten the AC by releasing some fluid. But even so, it was very difficult to flatten the AC. As you can see, I had to put my finger on the equator to put some vitreous pressure so that you could more easily withdraw the fluid. Because ideally, to be able to unfold it, you need to shallow a little bit the AC so that it doesn't fold back again. This was a 55-year-old donor, so it was quite. It had quite a tendency to unroll again. You can see the S mark, which that gives me a lot of tranquility because I'm quite sure that I put it on the right position. And then again, it's just about this little movement of trying to take fluid from the incisions and then doing this tapping on the top to be able to unfold these edges. Instead of editing this video, I just thought it would be nice to see it all. You can see that the edges are still unfolded, so I had to make sure that the AC was flattened again. It's all the time trying to flatten that AC so that the edges would be able to unfold properly. And releasing fluid through the paracentesis as here, and then it unfolds easily. Here I even had a collapsed AC, but that's only the way that you are able to unfold these little edges so that you have a rounded configuration of the graft. Okay, so once we're happy, we still have to put some fluid, and then underneath the graft, very on the edge of the iris plane, and you go to the center, and we use a 20% SF6 gas to fill up the whole AC to pressure the graft towards the cornea. And we leave that for about 10 minutes on quite a bit of pressure, superphysiological, and then after 10 minutes we release some of the gas. I'll leave the patient. And that's all. Thanks very much.
Gracias, Tony. Empezamos la discusión, hacemos algunos comentarios. Quizás el primero a Burkhard, si todavía está. Burkhard, are you there?
Yes.
Okay, just perhaps a practical question. Thanks very much for your videos and your talk. But I found quite interesting this Alcon lens model that with a small aperture. Is this commercially viable? Are you working with it?
No, the approach will be shown at the upcoming Academy in New Orleans. Mm-hmm. It's femtosecond laser-based approach. The company behind is Roviak from Germany, Hanover. The person who will present it is Holger Lubachowski and Omid Kermani. And they claim to be able that they can laser any kind of aperture, let's say it this way, in terms of diameter, location, and inner diameter into any IOL.
Okay. This is interesting. Much more than to be thinking in a particular lens, because then you can choose a hydrophilic, hydrophobic, or any shape that you'd like to work with, or in those cases where you're going to suture it on the sclera, possibly centration will not be so significant issue if you can do it later on. No?
That's the point, exactly. Yeah, it has a lot of interesting aspects, but also, of course, challenges like toxic elements that need to be prevented not to come into the AC, etc.
Yeah, it's a good idea. Very good idea.
I would like to make a question.
Yes, of course.
Okay, Burkhard, you have been talking about automatic capsulotomy, which is a topic that is in the rise, right? So you have been using the three types that are available, the femtosecond, the septo, and the capsulator, right? So which one do you think that will prevail? Because we're talking about the future, and we have one, which is septo, that needs to be introduced. It's an artifact in the anterior chamber, while the others are light. And one is more complex because you need a bulky instrument, while capsulator is mobile and is just in the new model that is not the one that you saw, even doesn't need a PI, a patient application device, So I think that for me, the three of them are promising, but which one is the one of your choice? You have to select one, and why?
Yeah, the capsule laser is for me too complex. It needs to be attached to one microscope. That means you are limited to that working place, so to say. And fortunately, they were able to get rid of the contact glass, but still you have to dye, etc., etc. And the rim is not that perfect. So I'm not convinced about the capsule laser. The Zepto is also something what I would say is too complex. You need another assistant who knows exactly what to do, etc. The surgery is not completely in your hands. You're limited to a certain diameter, and both procedures cannot reliably open the posterior capsule. So for me personally, the femtosecond laser with all the centration possibilities, individual parameters, etc., and the possibility to conduct a mini capsulotomy or a rescue capsulotomy, etc., is the way to go with the current technology we have available.
Okay, thank you. One question for Vladimir and also for the panel, because in the panel there are very well-trained and fantastic surgeons like Juan or Danny or Blanca or Karim. So, Vladimir, is any case of, in your experience, would you consider in some cases to use no sutures when you implant this kind of artificial iris?
I would never implant the artificial iris without the sutures, because I don't want to have contact of the artificial iris to the intraocular structures, because it induces inflammation, and even this is subclinical. You can see it on the macular edema, let's say years after implantation. So I would always try to keep this artificial iris away from intraocular structures with sutures or with whatever is possible.
Well, this is important. I don't know if some of you have seen those artificial iris being implanted as a cosmetic reason in people who wants to change the iris color. And I've needed to remove a couple of cases. I think that Elena also saw them, and they were implanted basically floating in the anterior chamber. So together with the removal, I needed to do in both cases a demexectomy. So any comments, Juan, Danny, on artificial iris?
My only comment is when at the beginning the company presents us or almost at me this artificial iris, they say that it could be implanted in the angle, in the residual or over the residual iris in these traumatic cases. I never did it in cosmetic cases, but I did some of them in traumatic, and I absolutely agree with Dr. Pfeiffer. It's not the proper way. If you implant that iris just touching the residual iris and the angle, you induce inflammation and glaucoma in all my three first cases. All the three eyes I implanted the artificial iris without suture in the angle, all three developed glaucoma and inflammation. I think the only way to implant that artificial iris is just suture it and far away from the angle and the other structures.
I totally agree with you. This was my early experience with this kind of prosthesis. Now I'm not using diameters bigger than 10.5. I am using the technique of suturing the happys or with the Tourkmani technique. I don't like the Canabrava technique. I think it's not, you can have the iris moving with this Canabrava technique, but this is my preference. But I agree completely with you. This kind of material should not touch with the iris, with the iris or the ciliary body, because the glaucoma was the root in the initial cases.
I have a question for Dr. Burkhard. Sorry. Do you do the posterior capsulotomy just right when you finish the surgery or later on?
So we have to decide if we are doing it on adults, you just implant the IOL, and usually the patient would stand up and go away. What you do additionally is you redock, which is possible without any sutures or something like that. You rescan, and what you see is the clear space between the IOL and the capsular bag, the posterior capsule, and the anterior hiatal membrane. We published that in Orange Journal. And you can then reliably and consistently do a primary posterior laser-assisted capsulotomy in any case, without touching the anterior vitreous. And the long-term data, which is now going to be published after 2 years, didn't show any significant additional risk or something like that. So, but it's something that needs to be decided by the surgeon, because you're taking away a lot of capsulotomies, etc., if you do this, because patients will not suffer from PCO then. In pediatric cases, it's completely different. There, you elevate the posterior capsule with an OVD, and then you are lasing the posterior capsule as if it's the anterior capsule. So you align the posterior capsule to the anterior capsule with Bochum formula. You have to use it to adjust a little bit the enlargement depending on the age. And that means that you can implant it back in the lens or whatever, and you don't need an anterior vitrectomy, which I think is the key for the horrible aphakia glaucoma in these young patients. And one of the reasons, at least if we listen carefully to the older people like Robert Stickman, etc., they didn't have any aphakia glaucoma in the past when they were not doing a vitrectomy. Nowadays, that we ask the people to do an anterior vitrectomy in all pediatric cases, you see 30% of aphakic glaucoma patients and a lot of them going blind over the years.
Okay, thank you.
My pleasure.
I just wanted to make a comment touching on the topic of iris prosthesis, and then I also have a question for Dr. Burkhard Dick. With regards to the iris prosthesis, I think that there would be two instances. One instance is when you still have a capsular bag, in which case you don't need any sutures because you have the capsular bag to support the iris prosthesis, but you also need to put the capsular tension ring, because if you don't and then the capsule contracts, then the iris prosthesis can extrude. The other instance would be when there is not capsular bag support, and then yes, I agree that you would need to suture or fix it to the sclera in some way, whether it's using the haptics of a lens that is stuck to the iris prosthesis or suturing it directly so it doesn't move. So I would fully agree with that. The question I had to Dr. Burkhard is, I've seen that in the video show how you're doing a primary anterior and posterior capsulotomy, and the picture you put was that of a multifocal lens. We know that sometimes there might be patients that have neuroadaptation problems and they may need an early exchange of the lens. So my question is, have you come frequently or how frequently have you come across a case that was requesting an exchange of the IOL in which you had already done both an anterior and posterior capsulotomy? Because then you can have issues with vitreous prolapse that you wouldn't have if you waited a little bit to do the capsulotomy later on.
Yeah, that is an interesting question. And actually, I had one patient. And what you need to differentiate, if you're doing a posterior capsulotomy, the anterior capsule is, shot in pieces. Yeah, and the vitreous is liquefied. If you are keeping the anterior highlight intact, which is the case with a primary posterior laser-assisted capsulotomy, then you can push back the vitreous, and the capsule will be kept intact because you have a completely intact posterior capsulotomy, well-sized. That's the big difference. And people love it, especially in Germany, because all these multifocal patients will very early come back if you're doing a refractive lens exchange, for example, on a routine base, like Euro eyes or something like that. The patients come back and complain about, the initial signs of early PCO, deteriorating their intermediate and near visual acuity, and then the capsulotomy is conducted. So there is a risk balance, so to say, here involved, where I would clearly be in favor of doing it beforehand.
Pregunta y question for Dr. Arrondo. One pregunta para la doctora Arrondo. ¿Diferencia en la eficacia entre el LT en ojos fáquicos y en ojos pseudofáquicos? So differences in the efficacy using the ELT in phakic or pseudophakic eyes.
I mean, we don't have experience in phakic eyes. We have always performed this treatment with the phakic surgery at the same time. And I think that's one of the reasons why we really don't know exactly the effect of this laser separated from the phaco. No? We saw that there was a reduction of 2.2, 2.3 millimeters of mercury after 1 year, which is not too much. That's why we think 1 or 2 millimeters of mercury is not too much. But if we also have a reduction in the treatment of these patients, that is the main objective and the main target of our laser treatment. In most of our patients, we decided to do laser if they have mild glaucoma. I don't think this laser is recommended for patients with moderate to advanced glaucoma, just to mild glaucoma and in patients well controlled with 1 or 2 drops. It's one thing that we have to remember, that this is a mini glaucoma surgery. It's not a proper filtering surgery. So we only recommend this treatment in patients with a controlled glaucoma with 1 to 2 drops, in which we will remove the cataract.
Okay, now we have to finish the session. And I want to thank all our friends, Burkhard, Vladimir, all my Spanish colleagues, and definitely this has been a great session in which we have learned a lot. I'm sure that will be our immediate future in our practice. Now we want to end the session with a message from Brill Pharma. And I want to remember you that we have the next session, which is going to be the session number 7, and at 3:45. But before, we have a very interesting invited session, satellite symposium from Johnson & Johnson. Now, Brill will close the session with a message from their company. Thank you.